From the heartland of the United States and one of the leading children's medical centers in the world, welcome to the Children's Mercy Kansas City Pediatric Bioethics webinar series. We invite international leaders to discuss critical and controversial issues in bioethics. Now, from the Bioethics Conference Center on the Adele Hall campus, here's Dr. John Lantos.
I'm taking the role, John Lantos' role today. Welcome to the webinar from wherever you are. I know we have many people who are connecting in from all around the U.S. and indeed from many other countries as well. So we're so glad that you're here with us today. We also have a live audience here in the room. And as the MC today, I'm going to take the role of introducing our speakers. And then once our speakers are done with their presentation, we're going to have plenty of time for questions, answers, and discussion. So when we're done with that, then we will be able to take questions from the audience here, but we also will be taking questions from those of you who have connected from elsewhere. And I just want to say before we get started that as you're listening, if questions occur to you, feel free to send those questions in during the presentation. You can also send them in after. And you'll do that by going to the chat box. So look on your screen for a chat box. It's in the lower right corner. And you can just type your question right into that box. The more specific with your question, the better for us to understand what you're asking. You also can tweet us your questions, and you can tweet them to hashtag CMBioethics. So that's CM as in Mary, bioethics all together. So please get those questions coming in as you hear the presentation. So it's a great privilege that we have two speakers today, presenters, to speak with us about their work. And we're going to hear from Dr. Marcia Griffin and Dr. Minette Sun. And Dr. Griffin is the director of the Division of Child and Family Health at the University of Texas Rio Grande Valley School of Medicine. And she's the co-founder of the Community for Children, along with Dr. Sun. And I'm not going to go on and on because it would take quite a while to describe all the work that Marcia and Minette have been doing, but we'll just summarize it by saying that both of them have been dedicated advocates for the needs and rights of children and families at the U.S.-Mexico border. And for the purposes of a bioethics discussion, I think it's important for listeners to know that this is not just a matter of what medical need a child might have, but it really gets all the way to the point of what rights, what human rights and rights do children and families have, and what are the actions we are taking or not taking to ensure those rights at the border. So Dr. Sun now works here in Kansas City with us as a critical care physician, so we're very happy that she's come here, but also she'll be talking about the work that she has been doing with Dr. Griffin in the past at the border and continues to work on together. She co-founded the Community for Children with Dr. Griffin. And finally, I'll mention that Dr. Sun has much other work that she does in global health, working in Mongolia and in Kosovo, performing or helping organize and performing life-saving surgeries for children in that area, and has been honored for her work in that realm as well. So if you all are ready, I don't know if you're ready, but I can hand over the microphone to you.
This right here, and then the
Color on
microphones
green.
are on. We're ready.
Okay.
All righty. So we're going to talk a little bit about some considerations in terms of ethical caring for the global child, and we're really pleased to be here. Thank you. I'm new to Kansas City, and so far it's been a good ride. It's exceeded my expectations. I actually came because I wanted to be at a children's hospital and see what that was really like. And it is truly different. So thank you so much. But yet I still get to have partnership with my friend, Dr. Griffin. So thanks for bringing her. I got to do this. You do this, and I'll do this one. How's that sound? We have no, that one moves that one. Okay. Community Children is the program that we developed that was related to our collaboration in the Valley, which we talked about a little bit at Grand Rounds this morning. So in terms of what is global health, what is the global child? The rise to prominence of the term global health has occurred in parallel with popularization of globalization, enhanced awareness of common vulnerabilities, and a feeling of increased shared responsibility for inequities present in the world today. It's a popular topic. If you look at different academic centers around the United States, many of them indicate the fact that they have programs or interest in global health. It's kind of a fashionable thing to do. It provokes interest, it provokes attention, but it's often not really clearly defined. It's often interchanged with the term international health, or it could be interchanged with public health. All of those are kind of have commonalities. Global health emphasizes the health of all people, both internationally and locally, and global health topics encourage trainees to think globally and act locally in the care of underserved children and migrant populations. There are unique competencies that are required for pediatricians to care for global health patients, including refugees, immigrants, international adopted children, and victims of human trafficking. And I think any of us who work with refugees or immigrants recognize the fact that you don't have to go to another country to do global health. We're going to the next one. All right. The common overreaching goal is the well-being of the global person, and this is embodied in each person and transcends differences between groups of people regardless of differences based on race, ethnicity, political affiliation, economics, culture, education, language, gender, age, or religion.
So I'm going to share a little bit about from the border and my perspective and what's going on with immigration enforcement in this country. And this is a map that is from the ACLU. It was printed in Harper's and Texas Observer, and it's by a journalist named Melissa Del Bosque, who spent many years on the border. But this is a reality on the border, and it is probably something that's not much talked about, but it is called the 100-mile border zone. There's not the same rights that those that live within 100 miles of the border have than what all of you in the center of the nation, although that is changing drastically in the last 2 years. You'll notice that 100 miles from the border, it really encompasses most of New York, Connecticut, New Hampshire. It includes Delaware, most of Maine, or all of Maine, you can see up there, Maryland, Michigan. And so to be in that zone, that 100-mile zone, means that Department of Homeland Security can come into your building or your home with not the same requirements that we have normally, that we think are rights, constitutional rights, that you have to have a warrant to come in. That is not true. It's not been true forever and ever and ever since I've lived on the southern border. You can see Brownsville on the southern tip of Texas, right in the center. If you don't know where Texas is, it's okay with me. It's right in the center, and at the very bottom is Brownsville, Texas, as far south as you can go. And that has been our reality, that we are subjected, we call it the no constitutional zone. So the things that I will describe that go on in Texas, so I'd like you remember on this slide that where Brownsville is, you see Laredo is going kind of up northwest, and then if you were to go directly east from Laredo would be Corpus Christi. It's not on there. I don't see it on there. But and then farther northeast is Houston. So that's kind of the area, because I'm going to be talking about hospitals in Laredo and hospitals in Corpus Christi, which are down by the border and within this zone. So this is what it looks like in our area. This is the U.S. Border Patrol, and I'm going to be telling you some stories that are a little shocking. I have to say that I work with the Border Patrol, and we work with the Border Patrol all the time in our area. They are border security. They have some of the best jobs, highest paying jobs in our area. In an area that's extremely poor, these are some of the best jobs. And entry level is $75,000 a year, plus benefits. And so we get many of our finest boys and girls, nieces and nephews, go into the Border Patrol, and they have to be torn ethically and morally because many of their family are undocumented or they know their history. So I talk about some of the Border Patrol. They are the largest largest law enforcement with no oversight. So if Kansas City police happen to kill somebody here, there's going to be an investigation, there's going to be a trial. They're going to look into that. That does not happen with the Border Patrol. And so that is something different that is in our area. Our area has we have about 1.8 million people. An estimated 200,000 are undocumented. They're all my families that I used to see at the Federally Qualified Health Center. Somebody in the family was undocumented. To have Border Patrol come on bikes, they're also in the brush, they're on horseback, they're in vans, they're in trucks, they're everywhere. I live a half a mile from the border, and so the Border Patrol are constantly patrolling my area. And so you can imagine the fear this puts in the families who have somebody that's undocumented, because now they're taking people out of their homes and separating kids that way by deporting them. Let me go back. There's 3,000 Border Patrol. We have Border Patrol, we have National Guard that are down there in the thousands. We have the military now, we have the state troopers there. And from time to time, we have militia who come in that are unofficial to help. And they are very scary because the Border Patrol doesn't want them there, because they don't know what they're going to do and they don't know who they'll shoot at. And so we're the militarized zone. This is now at the very bottom. You see Brownsville over here in Cameron County. That's where I live. It's right. We used to say by the border, by the sea. Now that's kind of pejorative term. By the sea means we get lots of hurricanes. By the border means we've got militarization and a lot of, those refugees. And so what you don't see on the map, it looks like there's nothing below us. That's Mexico. It's highly populated. There's millions of people down there. Many of our family, many of our friends live over there, and we haven't been able to go over there since 2009 because of the danger, not to us, although there is dangers to us that we could be kidnapped. Doctors are kidnapped if they go over there. But our friends in Matamoros, which is the city south of us, asked us not to come. My husband worked over there. He actually, disclaimer, my husband works for the ACLU. He's their border strategist. They ask us not to come over anymore because we're white. We're the güeros. And if we come into the neighborhoods, the cartels will signal them out, and then they'll go and kidnap them and torture them to get what's perceived as we might be a link to money in the north. So we haven't been over there since 2009. It's very sad. So there's two highways going north. If there's a hurricane, all those millions of people have got to go up that north. But it really has particular relevance in that I can't get, if I'm undocumented, there is a border patrol. This is the 100-mile border zone. That's the Border Patrol. So it's as if there's another border there. You have to stop. You have to present your documents. For if you're white, they say, "Are you a United States citizen, ma'am?" And they wave you through. If you're any other color, you're going to be stopped. Your car may be ransacked. And they will want more documentation. For the past bazillion years, we haven't had high quality or subspecialist on the border. We're now changing that with the School of Medicine. But if I needed a child to have surgery or to have something specific done, let's say she always worked in San Antonio. If I wanted to get a child up to critical care and get a cardiothoracic evaluation and have a surgery, I have to get through those checkpoints. And the parents cannot go through there if they're undocumented. They'll be deported. If a child, I'm going to be talking about a child, what happens there? So there's been times that I have had to fly and air transport a child over that checkpoint to make sure that they got where they were going. That's not exactly a thing we should be doing all the time. But this is a barrier. The people in our area call it La Jaula, which means the corral. They can't go south because of the dangers, and they can't go north because they'll get deported. So this is the case. I don't know if any of y'all heard about Rosa Maria Hernandez. She was a 10-year-old girl last summer. She had a problem with her gallbladder. I don't know the details of that surgery, but she was from Laredo. She was born in Mexico. She's been living since she was 3 months old in Laredo, Texas. They did not have a surgeon there. to do her surgery, and so they were going to transport her to Corpus Christi. Rosa Maria does not have documentation. This was on the news all last summer, and Rosa Maria went through the checkpoint, which is at her area. There's another one outside of Laredo. Went through there. She was stopped by the Border Patrol, who and the family did not send her mother and father because they don't have papers. They sent their aunt to go with them because the aunt was a U.S. citizen. So the aunt traveled with her, whom Rosa Maria knew well. She lived with the aunt and she'd been kind of a caregiver, Tia, all her life. The Tia went with her. She was stopped at the Border Patrol. The Border Patrol said that she could go. They were going to follow her ambulance to Corpus Christi, and they would stay with her the entire time, and that upon discharge, Rosa Maria would be arrested and taken from the family and put in detention. I got alerted, as did most of the advocates on the border at that time, and that this was going on. So we were calling the doctors at Driscoll Hospital. It was Driscoll Hospital, Children's Hospital in Corpus. We called there, talked to the doctors. They said their hands were tied. They couldn't do anything about this. We were calling the Border Patrol. We called Henry Cuellar, who's a congressman who represents the Laredo area. And I think he does Corpus Christi as well. And he said he was going to try, but the Border Patrol in Laredo are actually coming into houses and taking parents away, leaving 5 children alone in the house by themselves, and they would just take the parents away. So it was rampant in his community, and so he was outraged and was trying to do stuff. Despite this, we were not able to stop this. Rosa Maria had her surgery, and on the second day after her surgery, when she was still on pain meds, she was to be discharged. We had begged to not have her arrested, but they arrested her. They arrested her, and she started to go out of the room, and she was very distressed, and they took her back in the room and calmed her down. But they eventually, the Border Patrol, took her to an Office of Refugee Resettlement shelter in San Antonio, Texas, and she was deemed an unaccompanied child all alone with no support. ACLU had gotten involved and had been trying to organize the effort to not have her be arrested, because you can imagine do we have physicians in the room? Everyone is a physician? Some are physicians. A child with cerebral palsy, the caregivers generally know how they communicate. She was cognitively impaired and motor impaired. And so a child that has cerebral palsy may have pain, and you wouldn't know it if you weren't the caregiver. Or it would look like they're in pain, but they're really just anxious. And so they could be over-medicating her or under-medicating her if they don't have the primary caregiver or somebody's lived with that child. But they took her away. ACLU immediately filed a lawsuit, of which they asked me to write a letter of declaration, much like I spoke about this morning. I wrote a letter of declaration about the dangers that they could kill this child, that this was not morally correct as well, is that to consider the ethical considerations, because she was in pain, and she was not going to have anyone around her that could express what she was feeling and to take care of her. She was with complete strangers. She was there for a week, and at the end of the week she was released, and the ACLU was able to prevail, but not without her being alone for a week when she was in pain. So I ask you at the end, we'll talk about this, the ethical considerations for Laredo physicians, who most of them know that they're going to have to be stopped at the checkpoint. And how do you make that decision for a family? The ethical decisions for Driscoll Children's Hospital. Do you have to have Border Patrol in the room? Do they have to keep the door open all the time to be able to watch in case Rosa Maria jumped up and ran away? And the role of children's hospitals across the country in dealing with these issues, we are all mandatory reporters, and I think we have to consider that. I have called Child Protective Services in my state to report what's going on in the Border Patrol processing centers and in some ORR facilities. And I'm sorry, can you talk?
Yeah, so that's an interesting concept to me, because I don't know that I would actually have thought that if I see this kind of injustice that I could report it to CPS. So she's literally calling CPS all the time about governmental agencies that she thinks are, being inappropriate and harming children.
Or we had one hospital that a child had been transported there for pyloric stenosis surgery, and the parents were undocumented, and the nurse decided it was her duty to call ICE to tell them that they had people there. And I don't know if that's considered part of the medical record, but if so, I am putting forward that I think that's a violation of HIPAA, and that person should be fired. And everyone should know in the hospital that if you divulge anything in there, that it's a HIPAA violation. So now I'm going to not talk about immigration enforcement, which I could tell you lots more stories of those kind of incidences. But when I worked in the Federally Qualified Health Center, most of my patients were undocumented, and they didn't have funding. And so I was always, isn't this boy just cute as could be? He's not my patient, but he might as well have been. He's just on Google to find a fracture. But they were constantly coming in, and I would be reading the film, and then I'd say, your son or daughter has a fracture of their arm or wherever, and it just seemed normal to me that kids get fractures when they're kids. And what happened is that every time I would say that to a parent, the mother would start crying, or the father would get upset. And then because the mother was crying, the kid would get upset and feel guilty because they had done something wrong, when actually they didn't have the money to go see an orthopedist. The orthopedist in our area were charging $280 to come in and get an evaluation and then have it casted or not, and then they would have to have follow-up to take it off, and that too required an extra pay. And so the parents were having to make these hard decisions. They didn't know where they were going to come up with that money. And so I got finally, after several hundred of these, it dawns on me I could do something about this. So we started what we called the Fracture Fund, and I called everybody I knew to donate to the Fracture Fund, so that then I could tell a parent, and I got some orthopedists to give us a discount on being able to see our kids. And what I would say is, the bad news is your daughter has fractured her elbow. The good news is, if you have $25, we will cover the rest for her to be able to go and have the evaluation. Because in our area, the orthopedic surgeon don't actually aren't. You're in a children's hospital, so that's different. But orthopedic surgeon told me that there's actually not very many emergencies in orthopedic surgery unless you're in a trauma hospital. And so what they do is that if the parent usually takes them to the ER first, they get the x-rays there, they read them and say, yeah, you've got a fracture, and then they send them back to me. So now they've got an ER visit bill, they've sent them back to me, and then I'm going to send them to the orthopedist, and then they have to go back to take it off. So it was like a big runaround. It was terrible. And so what we did was get the Fracture Fund, and I would say, Juan broke his arm. If you've got $25, we've got an appointment for you, and we'll cover the rest. We're going to cut you a check to do that. And then we'll also, because I thought I was good in doing that, and then, they would get that done. And then I worked with the school nurses a lot, and one day I got this call from a school nurse, and the school nurse said, Dr. Griffin, I'm about to call CPS, because this boy that, you diagnosed with a fracture, he was coming in, and I noticed that his cast was looking like it was going to fall off, and then the next day it was gone. And I said, oh, you went to the orthopedist to get it taken off? And the boy said, no, my father took it off with a chainsaw, because they could not afford to go back. And so the school nurse wanted to call CPS on the father for using a chainsaw. And I said, please don't do that. That's his only alternative. And when I told this story to Dr. Sun, she's like, well, the orthopedist used a saw. It's just not as big as a chainsaw. And he has a license to use that, and the father doesn't need a license to use the chainsaw. So that's just one of the issues that we deal. So, and who is responsible? You know, is the federal government supposed to take care of everybody? Is the state of Texas? I can tell you it's not going to. Is our county, which are two of the poorest counties in the country? Is it the clinic? The clinic was like, you know, get some pay, Marcia. Is it the parents who are doing their best? And what are the ethical, I think there's strong ethical considerations for our society to take care of people. So now it's Dr. Sun's turn.
Yeah, all right. So we're going to shift gears a little bit. Instead of talking about refugees and immigrants, talk about individuals who go maybe other places to practice medicine globally. Oh, I got to do this too. Don't you do this one? Okay, we're going to get this show right.
Yeah.
Next. All right, so this is a quote from a young doctor who worked with Samaritan's Purse in Africa, and it says, life and death in the third world. What is the driving force?
Oh, I'm sorry.
Maybe we're going to get this.
No, we're not going to get it.
What is the driving force behind medicine? How is it different in various parts of the world? And the bottom line one is good patient care that prolongs life and reduces suffering, but that expectations in different parts of the world are very different. That in the U.S., you know, typically the people I care for, they expect to live and they really assume everything will be done, even if it doesn't need to be done, to keep them alive as long as possible. But in many other countries, people actually have the expectation to die and are very grateful when help is given to allow them to live a little longer. And as JC mentioned, I've had the opportunity to be in Mongolia for many, many years and establish a program there. When we first went there, they actually did cold circle arrest, and I actually got to see that done several times, which is not something I think I'll see again in my lifetime.
Do you know what that is?
Where instead of using a cardio bypass machine to cool the body to be able to do heart surgery and have a longer period of time, they actually pack the patient in ice, which is old school, like, you know, that used to be the initial way people did that. And at the time, this was probably in the maybe even the early 90s or the mid 90s. There were only, I think Russia and Mongolia perhaps were the only two places that still had centers that were doing that. But subsequently, we were able to establish perfusionist, which is the heart-lung machine, and establish a program for moderately basic, what we would call more simple cardiac disease here, more simple surgeries. But that obviously was a different practice and a different model. So some of the challenges that I think of and I think about when I travel places to go, and some of this is from what's called the Unite for Sight, which is an organization I've had some work with in the question of medical tourism. You know, is it self-serving? Who is it a value for? Is it a value for me, the visitor, or is it not really a value for the community? There's often unmet expectations. You know, we take individuals who can't speak the language, maybe don't have the exact medical expertise needed, and there's really not any accountability. Sometimes it's ineffective, it's temporary, the root cause isn't addressed. You know, I can go to Nepal and treat parasites, but I don't treat maybe the sanitation or the water issues, and those are going to return. It imposes burdens often, if it's culturally irrelevant, or I think of people going in and taking medical waste and not packing it out. There's so many examples, and then often maybe it's not the standard of care and it's not sustainable. So those are some of the things that in terms of training residents and medical students to do work in other countries that we try to think about from an ethical issue. This is a young lady named Boggie, and this is one of the ethical dilemmas that I faced in my career. When you travel and you set up programs with people, you work with a team, and one of my things I tell my students is to work with a team that you actually trust, because you may be making decisions that are difficult to make, and you need to make sure it's people that you really rely on. And often there is a lot of pressure from administration or from political people or from the community to do certain procedures or to take certain patients that maybe aren't the best choice. You know, I could go and we can do 20 VSD repairs, and those people, it's a life-saving surgery. They will survive. It's just that they're not going to die tomorrow. My partner calls it the allure of the blue child, that they want you to do surgery on the child who's the most sick, the bluest, or that they know will imminently die. And you might argue, well, yeah, that child's going to die. Maybe we should try that or not try that. And we did a more complicated surgery on Boggie. It was a shunt type of surgery, and she didn't survive. And I had a lot of difficulty dealing with that in terms of we made a bad choice for this child, I thought. her family was much like the families I described in other parts of the world, where they were so gracious. Every time we go back, they come and they thank us and they bring us gifts. And I want to say, oh, you don't understand. Let me tell you what really happened. But that's the circumstances, and that's the center. So I try to teach my residents and my fellows to really be aware and cognizant of who they're working with and the decisions that they make. Another thing that has occurred in some of my practice is the thought of team and personal safety, which is not early on something I thought much about. This is actually a reference, that's an excellent reference from the AAP in terms of any program hoping to set up a global health and pediatric education. And actually one of your faculty is one of the co-authors on this, Jennifer Watts. And in it, it actually has what's called a risk reduction agreement. So if you think about traveling and you think about taking these kinds of trips, actually one of the most dangerous things is actually travel itself. That more individuals who would travel die from trauma, and that's really actually a big deal. So we'll go back, I'm sorry. Once in Kosovo, we were in a car wreck with another vehicle. We were in a van, and there was a car, and it was carrying actually a groom and 3 other gentlemen. They looked like boys, but they were men. And we had the car accident, and 2 of those individuals died at the scene. And we were actually the individuals who had to care for them before emergency surgery came. It was in a village outside of Pristina, and there actually became a pretty significant crowd gather, and it was a pretty hostile crowd because it felt, the feeling was that we had caused this on their children. At the time, NATO, the UN peacekeeping, was there in Kosovo, and so a group from that organization from Germany actually came and helped us and got us assistance, actually got us safely out of that situation, and also provided help to get the children to the hospital, which was the hospital we were actually working at. And so that was really made me more aware of the fact that whenever I do this or I invite people with me, that I actually have some responsibility for them. So I really like the idea of them actually doing this risk reduction agreement. They look through it, you kind of come up with what are the things in this community that might be of danger and how can you reduce that risk. The next day of interest, this group from Germany came to meet with us at the hotel, and they were just kind of checking up on us, seeing how they were. And we obviously, as physicians and nurses, we just went right back to work. And their captain was actually sending them back to Germany to do debriefing and to do crisis kind of counseling. And my team hadn't even taken the time to reflect or to be introspective or to deal with it at all. So that's another issue that I think that we can improve on, at least in terms of the people and the trainees that I take and work with. Okay, and this is just one of the selfish opportunities when you do get to travel the world, that you get to take great pictures. So that's very self-serving, but I'm happy that that takes place.
I want to just butt in here because I'm sorry, I'm going to say. Okay, she's elbowing me.
She's trying to praise me.
No.
We have this abnormal, mutually exclusive relationship that we adore each other. So
well, we do adore each other, and Dr. Livingston, who's in the back of the room, is the trio of mutual admiration. But Manette's been going to the Mongolia and all these areas for years. She does not do medical tourism, but goes years and years and trains and gets trained from them as well. And in 2009, she was actually given the award of Mongolian Physician of the Year, which had never been given to a physician outside of Mongolia. And I think it speaks volumes about what she brings to that community, and they're valuing her as well. So I'll shut up now.
Okay, thank you.
You want me to go on?
We wanted just to introduce some of the references and some of the resources that are available for the thought about ethical considerations in global health, and some of those are here. Children's Mercy actually has a robust involvement in a lot of the things, as I showed a while ago. That's amazing. Stanford has some wonderful models online that you can do, that you can work through kind of case scenarios. I mentioned United for Sight just because I'm familiar and have experience with that. And then there's lots of programs in the United States that you can actually go online at any time and hook up with a program and go somewhere or do something if you have that desire. But as I said, I'm caution people to work with teams that they know and or trust.
So now I think we're opening it up for questions.
Yes, absolutely. Thank you. far as questions go, for those of you who are online, please send us your questions. You can type them into the chat box as a reminder, especially if you've joined the webinar after the intro when I pointed this out. There's a chat box in the lower right corner of your screen. You can type in questions there and send them to us. You can also tweet your questions to hashtag CMBioethics. That's CM as in Children's Mercy Bioethics. And from the audience here in the room, I don't know if there are any questions that you all want to start us out with.
Or comments? Yes, ma'am.
This is a little bit of a self-serving question, so just tell me to be quiet. We can talk about it afterwards if you want.
Okay.
You have three philosophers in the room. I know
Okay, who are they?
Jeremy, Christina, and I.
Okay.
And like I don't know about you guys, but I normally feel like I know how we can help with ethical issues. We clarify, we critically reflect.
Yeah.
We sort of conceptually sort things out. We make recommendations or sort of argue the table or against something, and then we share our work. This is like one issue, I know Christina and I were talking before, where I feel like I don't know how we can help with our philosophers' hats on with this issue. Like all the work that you're talking about, it's so amazing and so important. And a lot of the strength of it seems to come from multidisciplinary networks. So I was wondering, my question is, do you ever work with philosophers or bioethicists from our background? And if so, how do they help? How do they help?
Well, so my career is in the ICU, and so I actually have some exposure, obviously, to ethics consults and to decision making. And I know that there's strong programs here and courses that you could take. In my training, they actually exposed us to some of that, and I think most intensivists get exposed to that to some degree. And so that kind of the paradigm or the way that you think about things, I think, has helped. So I would say very much so that it's been a benefit. It's not the kind of situation where we make a consult at that particular time, but maybe just the exposure and the experience that you guys have lent to, at least myself and my trainees, has been a benefit. Does that make sense?
Yeah, in more of an educational capacity.
Right.
Leading up to being like
right.
on the border. And, like,
Right.
Yeah. Both of us want to say, and we didn't say at the beginning, we're no ethics experts. We really brought these cases to have a dialogue with you about this. And so we appreciate your input. But I also think that you have a huge role to play in that, partnering with folks like us and hearing stories and then writing about it.
Mm-hmm.
And so if you write about it or speak about it or write op-eds about it, you're advocating, but you're also helping the profession and I think our society as well to think about these issues.
Quick question, is it, for many healthcare professionals, the moral distress of these issues, of seeing them, hearing them on the news, taking care of patients and families, is something that lives with them, I think, with these issues that we're seeing, and even more so now than we did before. What are some suggestions of how we can move beyond that moral distress and take action to share? I know you mentioned for the philosophers to write about it, to write things. What other ways can we, maybe, would you suggest that we as healthcare professionals deal with the moral distress of caring for these patients and families, trying to do what's best for them, but running up to obstacles?
I think that is the issue that we all deal with all the time, because we are living in a world that's putting up obstacles for these children and families. And so that does lead to moral distress. And I believe it's also leading to physician burnout. That there's a lot of things that physicians used to be able to decide on and do that they no longer are able to do, that we've got a different healthcare system now, that we're not so much in control of. So I think that what I think is just what I see is that you share these stories with like-minded people in your institution, and that you become the cohort of friends that supports each other. Because don't take it alone, and your family can't understand it often, or may not, or your significant other. But what you have had to deal with is you were fighting for a child, say, that you thought deserved to have care, and you weren't able to get it for them. And I happen to liken that to the immigration attorneys. And I think we're working very hard right now to put together, we have a program called Witness to Witness for immigration attorneys, because a lot of times where they used to be able to fight for their clients and get them asylum, so many changes have been made in the last 2 years that they're getting a lot of negative decisions so that their clients are deported. Those attorneys are having serious problems, and the witness, in fact, some of them have become suicidal or they get out of the business altogether because they feel like they can't forget the clients that they couldn't save, and they know they're going back to death or to a horrible life or to being prostituted by a cartel. And so they can't sleep with those cases at night. And so we started Witness to Witness, which is our family therapists provide free phone call counseling. So if they're in crisis, they can talk to a family therapist to deal with that. And they'd be available for physicians as well. I think setting something up in this institution, that if you're going to set up trauma-informed clinics and hospitals, to have that organization or network of champions that will champion the patients but champion for each other, that you have somewhere to go. And then I would take that group, because pretty much they're going to be people you're going to want to be friends with and that you'll be friends with, and then I would go drink and party and raise hell together.
She's good at that.
And enjoy life together while you're in the middle of a struggle. But that's needed in support as well.
One of the things that we've kind of refocused in terms of our Community for Children project, we say it's for social justice. We say it's to treat residents and students, teach them how to do advocacy. One of the things that seems to me over the last 5 years we've emphasized more is actually bringing in people who have expertise in terms of policy and legislation. Like, that's really where it matters. That's how it's the only way it's going to change. We do need to take care of ourselves, and we need to be able to continue to do what we do. But I've learned quite a bit from participating in this program from, how do I advocate, my legislature? How do I advocate in the city for changes that might make a change in policy and help this situation? And, we can all vote.
Yeah, thank goodness. And also make sure that, you kind of as a group find out what the legislation is going on in Kansas. What are they trying to do to support, and what are they trying to do to hurt families? And you be the conscience. I am an ethicist. I am a philosophist, and speak up, because it's a proud career and occupation, and we need you desperately right now.
Thank you. We have a question from the online.
We have a couple of online questions. The first one, as I'm looking at it, is trying to kind of situate the work that you all are doing and describing for us within larger codified systems of professional responsibility and ethical responsibility on the part of clinicians. So they say, nurses have a responsibility to pursue social justice for everyone in their code of ethics. Do physicians have anything similar? And since I happen to have my medical students that I teach do a comparison and contrasting of various codes, I know the answer to this is yes, they do. It's not quite as robust, I would say, as the nurses get at, but just to cite it, and I'll open it up for you all to, because I have it right here in front of me. The AMA Principles of Ethics say that a physician shall be dedicated to providing competent medical care with compassion and respect for human dignity and rights, so getting to that angle of things, and then also that a physician shall support access to medical care for all people, and irrespective of any other facts about them, just the fact that they're humans is sufficient for that. But if you all want to take that and run with it a little bit further, we welcome that.
Well, I have been very heartened over the last 5 years since the American Academy of Pediatrics has really stepped into an advocacy role, much more than they used to in the past, that they brought along, I think, because of seeing all the things that are going on that are against our patients and against vulnerable people in our communities, that the Academy of Pediatrics actually sent out many press releases about the harm that we were inflicting on children and the trauma that our country was inflicting on them. that 13 medical associations signed off on this letter together. And I will miss somebody, but it's family practice, it's OBGYNs, it's the AMA. The AMA wrote themselves an article about what we were doing to immigrant families and the separation of children. So I think that there was 13 other medical organizations that signed off. I went and spoke to anesthesiologist or conference. I was like, what am I going to say to the anesthesiologist? And they were probably the most vocal crowd, that they were outraged by what was going on. And so we are a service institution. We came to care for people, and sometimes I think people forget it and we forget it, but I think that is critical. I was on a webinar with ACLU right after the ACLU had filed their charges, and we had written letters about the separation of children, and they filed their lawsuit for separated children, the Class Act. And so the administration had to reverse that. They ended up reversing the zero policy separation of children. And so Lee Gallant, who was the lead attorney for ACLU, was on the webinar with me. And we were in separate places. He was in DC and I was on the border. And somebody on the webinar asked, what do you think made the difference in changing that policy? Now, I think there's a lot of things that made the difference. The crying child, having that recording on Publica, that contributed. There was many things. But Lee sat there and paused, and he said, I can tell you what made a difference. It was doctors speaking up. He was like, I've never seen it like that. And he's like, not only would they not shut up, they wouldn't give up. They just kept speaking and standing up and protesting and writing and being at their seats of government. And he's like, that's what made the difference. The doctors made the difference. So I think all of us can make a difference, no matter what we are. And God bless the nurses. You know, they've always been way ahead of us as physicians in doing the right thing.
That doesn't actually surprise me that they would be more forward in that thinking, actually, because and the trips I talk about, and I act like we've done such things, the really significant things that's made a difference is the nursing and the education and the respect that the nurses there have now garnered, because they actually are advocates for the patient rather than just taking the doctor's orders. And if I had to say one thing that made a difference, has been the nursing care in those communities. So thank you.
And just to give equal voice, I have the nursing statement in front of me. So Provision 8 says the nurse collaborates with other health professionals and the public to protect human rights, promote health diplomacy, and reduce health disparities. And the profession of nursing collectively through its professional organizations must articulate nursing values, maintain the integrity of the profession, and integrate principles of social justice into nursing and health policy. So again, I think it feels a little bit more robust and full-throated to me, but
copy it and put it in.
Just have the AMA adopt those as a kind of on the end of theirs there. We do have another question. Actually, at this point, it looks more like a comment, but you can pick up on this, I'm sure. One of our online participants lives in Colombia, that is in South America, and right now, as we know, are experiencing a humanitarian crisis with all the issues that are going on in Venezuela, which neighbors Colombia. This crisis goes beyond a political crisis, and it not only affects Venezuelans who migrate, but also Colombians, because it's hard to handle the limited resources that we have for our Colombian citizens, and then on top of that, handle complex cases of Venezuelan citizens as well. They go on, it becomes hard to put out the fire, in quotes, of serious clinical situations, such as assisting the delivery of a preterm infant or offering ICU management, and then not being able to guarantee proper follow-up for those babies, just to cite a couple of examples. As healthcare providers, there's a lot of moral distress related to handling this immigrant population with limited resources. So again, not exactly a question, but kind of commenting on how they're seeing these issues in their own context.
I think that's very articulated point of a lot of our concerns is how do we take care of them, especially on the border. They end up in, they and their children are in our emergency rooms. And how do we take care of them? That's some kind of charity care. So how do we as a society and as a global society, this is not going to go away. The migration of children and families is not going away. So I think we need to think of it in a global perspective, not each individual country having to absorb what's going on near them with all of their resources, but find a way for us to do this as the human family on this earth. And I think that is an important thing. I think it's interesting that we had some of our U.S. officials on the Colombian-Venezuela border saying they could not close their borders, that they needed to let all of the Venezuelans come in. At the same time, we are putting up walls and telling people they cannot come into our country. So we certainly have a lot more resources than they do in Colombia. So good question, good comment. I think it needs to be solved globally.
Another question here from the audience.
Yeah, okay, now it's on. Thank you very much for your talk. I really think we need more people like you to make advocacy and speaking out. And especially, I think it's important to dismount both the stereotypes and beliefs that common people have about this, because I'm myself Italian, and right now the political situation I think is the biggest problem we have for what concerns immigration, especially at the southern border, with people coming from Africa, but also people coming from Syria especially. And the problem is that the lay people don't perceive this as a problem in the terms that you frame it today. And so I always wondered, how can we make them more aware and more empathic toward this kind of situation? Because the common discourse is people come to our country because they want to be healthy and they want to have a happy life and have success, and just take out our resources, and like it looks like they're coming to steal something, which is of course not the case. The problem is making them understand why other people would put them in the situation to go in a country where they don't know the language, they don't know the culture, and they really don't care to stay. Like most of the people coming to Italy, they come there because they want to go somewhere else in Europe. They don't really care to stay there. So how do you think it's possible to make people aware and emotionally get it,
Yeah, no, I think it's really hard. We've got to see the video this morning, which I thought was telling, in that people telling their story, I think, is one of the few ways that, and me telling stories that I've actually experienced to friends. I have friends who literally think that nobody in the United States doesn't have great medical care. I'm like, no, we can't even get the fracture fixed in the border, and they almost don't believe that. And so I think telling them specific and real stories, or maybe having them exposed to the kind of stories that we heard today on the video, would help, but I don't have good answers.
Because the problem, I think, is with legislation. We have a problem with the law right now, but the politicians cannot change it because they don't have consensus.
They don't. Right, the majority don't want that.
Yeah.
Well, we're living there.
I don't know. I'm going to leave this on a note of hope. Because in our community, we are a community of immigrants. We have the port and court watchers. But the port watchers are the ones that go to the bridges. And they're moms and pops, they're teachers, they're secretaries, they're retired Marines. They are there on the bridges taking tamales, checking to see if people are sick, giving us a call if they are, what can we do? I call the Mexico doctors. They are on all the bridges taking care of people. And they have responded in ways that it would put people to shame how they could talk in such negative terms when you have this whole community showing up to take care of people, to take them into their homes, to take them into their churches, to let them be safe for a night. And I see that popping up everywhere. It's certainly here in Kansas. You have a whole community and professionals who are making films and providing connections. And so that's who we are. That's who we are as a country and a people, and it's who we want to be. And I think that's, we want to be able to take care of people, and we can solve this. If we can put people on the moon, if we can do some of the things we can do, we can figure out with other great minds how to solve this migration problem, or do it with dignity and without killing our children, without destroying the future of our world, which is our children.
She's very optimistic and always hopeful. And she's the passionate, emotional. I'm more the put your big girl panties on and let's get it done. But I think, I believe all of that's just founded in ignorance and in fear. And the only way I've ever been able to overcome that was on a personal level. So I'm not as hopeful, but I'm going to stay her friend, so maybe I'll get some of that.
Thank you.
I would like to end with one, I'll put it as a provocative question. I think many of us who come from a more liberal, progressive viewpoint on these matters, such as myself, are very reluctant to accept President Trump's declaration that there's an emergency situation at our southern border because we don't like the kinds of solutions that he wants to propose. But the more I've listened to what you've said this morning here, it seems to me that there actually is arguably an emergency situation, not one that calls for walls and excessive, brutal kinds of crackdowns and fences and stuff like that, but one that does call for an influx of humanitarian resources, greater court personnel, all the kinds of things that would help make for a more humane asylum process, immigration things. And I'm just wondering, is that you're on the front lines, is that your viewpoint as well?
Yes.
That arguably there is an emergency, but it's just not one that in any way is going to be addressed adequately, if not made worse by the kinds of
The Doctors Without Borders put out a report in 2017 as well called The Neglected Humanitarian Crisis on the Border. And it's about the people who had to leave their countries in Central America. I'm just talking about them right now. And that it is as worse. What they're experiencing in their home countries and on their journey is as bad as any other war-torn country that Doctors Without Borders is in.
We should be able to spin the language, the fake news language, and turn it to where it is an emergency, but these are not the solutions.
And again, it's like this is at least as bad as natural disasters. I mean, people's lives are being ripped apart, the situations that they find themselves in after human choices that are made in terms of policies and horrible governments that are turning against their citizens and things like that, drug cartels overrunning. But the end result is that you have humans who are homeless, children who are being raised without parents, and these sorts of things. It just seems to me like it is actually an emergency. It's just one that calls for a very different set of policy responses than what we're hearing from our current situation.
Thank you.
Thank you very much.
Thank you to everybody. And thank you to everyone who logged in. Please stay tuned for news of a future webinar coming your way, and we'll close with that. Thanks so much.